I would like to thank the organizing committee for inviting me to talk on management of children with hypodiploid acute lymphoblastic leukemia and to share with you our experience at CCHE in treating these patients. Hypodiploidy occurs in 1 to 6% of pediatric B precursor ALL. ALL with less than 44 chromosomes have particularly a poor prognosis. However, its prognosis is improving due to the application of increased chemotherapy intensity and hematopoietic stem cell transplantation, which is the standard approach for hypodiploid ALL in first complete remission. However, the transplantation has been questioned in the era of minimal residual disease assessment. Hypodiploid ALL subtypes include near haploidy, having 23 to 29 chromosomes, which is characterized by a younger age at presentation. The low hypodiploidy, having 31 to 39 chromosomes, which is characterized by older age at presentation. And high hypodiploidy with 40 to 43 chromosomes, and is usually associated with complex karyotypes. The high hypodiploidy with 44 or 45 chromosomes have better outcome than other hypodiploid subtypes. Mass hypodiploidy forms a diagnostic challenge. A frequent phenomenon in hypodiploid ALL is doubling of the chromosome content, resulting in clones with 50 to 78 chromosomes in the hyperdiploid and near triploid range. Hypodiploid ALL sometimes harbor blast cells of two different sizes, where the smaller blast harbored near haploidy and the larger ones high hyperdiploidy. The double clone may be the only one detected at diagnosis and resulting into a masked hypodiploidy. Mistaking masked near haploidy for the true high hyperdiploidy could lead to error in risk stratification and hence treatment failure. Masked hypodiploidy from true high hyperdiploidy can be distinguished by cytogenetics, where the masked near haploidy have mainly tetrasomes, in contrast to the true high hyperdiploidy, which mainly will have trisomies and some tetrasomes. FISH or DNA index by flow cytometry will show two clones in the masked hypodiploidy and only one clone in the true high hyperdiploidy. By SNP array analysis, the masked near haploid cases are distinguished by having loss of heterozygosity involving all chromosomes that are not gained, whereas the high hyperdiploidy cases mostly will display the retained heterozygosity in all chromosomes. The near haploid is characterized by genetic alterations that target the receptor tyrosine kinase signaling, the RAS signaling, and the Ikaros F3 gene, while the low hypodiploid ALL has somatic genetic alterations that involve the Ikaros F2 gene, the RB1, and in particular the TP53 mutations, which are often inherited. Despite recent improvements in outcome of childhood ALL, patients with hypodiploid ALL have continued to fare poorly. In previous studies of ALL, outcome for patients with fewer than 45 chromosomes has been very poor. The Children's Cancer Group studied 23 patients having less than 45 chromosomes who were treated in the 1990s. The 6-year event-free survival was 25% for patients with 24 to 28 chromosomes and 40% for 33 to 44 chromosomes. In the later COG study on 39 hypodiploid ALL patients treated between 2002 and 2006, the 4-year overall survival was 54%. The CIBMTR reported in their study on 51 hypodiploid ALL patients from multiple centers who underwent BMT in first remission or second remission, a 5-year disease-free survival of 37% for less than 44 chromosomes, and 64% for 44 or 45 chromosomes. The St. Jude Children's Research Hospital in their earlier study reported a 5-year event-free survival of less than 30% for patients with less than 45 chromosomes. Recently, St. Jude reported a 5-year event-free survival of 73% for 20 hypodiploid ALL patients treated on total 15 and total 16 using MRD-guided approach. The 5-year event-free survival was 85% for MRD-negative patients compared to 44% for MRD-positive group. And 91% for the MRD negative patients and treated with chemotherapy alone. At Children's Cancer Hospital, Egypt, a total of 2,804 patients were newly diagnosed and treated on a protocol adopted from St. Jude Total 15 during the period between January 2008 and December 2017. B precursor ALL patients constituted 80% with a total number of 2,245. 92 patients had 45 and fewer chromosomes, of whom 63 patients had 44 and 45 chromosomes, 22 with specific genetic alterations of known prognostic impact, and 41 without specific genetic alteration, and only 3 patients had 44 chromosomes. This group of patients are not included in our analysis. 29 patients constituting 1.3% of the B precursor ALL patients had 43 and fewer chromosomes, 10 with near haploidy and 19 with low hypodiploidy, and none had high hypodiploidy with 40 to 43 chromosomes. Their age range between 2 and 18 years with a median of 10 years. The white blood cell count at presentation ranged between 1,000 and 86,000 with a median of 5,400. 69% of the patients were males and 52% were in the older age group, 10 years and above. About 79% of the low hypodiploid were males compared to 50% of the near haploid. 68% of the low hypodiploidy had older age at presentation compared to 20% of the near haploid, which was statistically significant. On the other hand, white blood cell count at presentation was significantly higher in the near haploid. 68% of the low hypodiploidy were NCI high risk compared to 40% of the near haploid. 44% of the near haploid had MRD less than 0.01% on day 15 of induction therapy, compared to 22% of the low hypodiploidy. About 63% of the patients in each subtype achieved MRD negativity at end of induction. Relapse occurred in 12.5% of the patients with negative MRD on day 15 compared to 63% for the positive MRD group. As for MRD at end of induction, 29% of the patients with negative MRD had relapse compared to 90% for the positive MRD. These differences were statistically significant. The 5-year event-free survival was 41%, and the relapse-free survival was 48%, and the overall survival was 41%, which was similar to the event-free survival, which denotes that we were not able to salvage the relapsing patients. The 5-year relapse-free survival was 39% for the low hypodiploidy versus 66% for the near haploidy, but this difference was statistically not significant. The 5-year relapse-free survival was 87% for patients with negative MRD on day 15, and it was 100% for patients who received chemotherapy only, versus 30% and 20% for patients with positive MRD on day 15. These differences were statistically significant. The 5-year relapse-free survival was 68% for patients with negative MRD at end of induction, and it was the same in the patients who received chemotherapy only and in the patients who underwent hematopoietic stem cell transplantation. On the other hand, the relapse-free survival was dismal for positive MRD at end of induction. And we were not able to assess the role of BMT in this group of patients as only one patient was transplanted. My concern was for the positive MRD on day 15, as they had also a very dismal outcome. So further analysis was done to assess the relapse-free survival for patients who had negative MRD at end of induction in relation to the MRD on day 15. The 5-year relapse-free survival was 87% for those who had negative MRD on day 15 and 60% for positive MRD on day 15. After excluding patients who underwent transplantation, the 5-year relapse-free survival was 100% for patients with negative MRD on day 15, compared to 44% with positive MRD on day 15, and all these groups had negative MRD at the end of induction. This difference is statistically was found to be significant. The larger study on outcome of children with hypodiploid acute lymphoblastic leukemia was reported by Pewe et al. 2019 in the JCO. It is a multinational retrospective study that included 272 evaluable hypodiploid ALL patients recruited from 16 cooperative study groups and treated between 1997 and 2013. They reported a 5-year event-free survival of 55% and overall survival of 61%. Patients treated on MRD stratified protocol had significantly better event-free survival. Patients with negative MRD at end of induction showed significantly better event-free survival than patients with positive MRD at any level. Hypodiploid ALL with 44 chromosomes had better event-free survival compared with the other hypodiploid subtypes. Comparing survival of patients who received chemotherapy only versus transplantation after excluding high hypodiploidy with 44 chromosomes, the disease-free survival and overall survival did not show statistically significant differences. Similarly, the disease-free survival did not show statistically significant differences between the chemotherapy and the transplantation among the hypodiploid subtypes. For patients with negative MRD at end of induction, transplantation did not show any survival benefit over chemotherapy only. For patients with positive MRD at end of induction, the 5-year disease-free survival of transplantation showed a trend towards better outcome, being 56% versus 40% for chemotherapy only. However, the differences is not statistically significant. This study concluded that MRD stratified treatment improved the outcome for children with hypodiploid ALL. Allogeneic transplantation did not significantly improve outcome, and in particular for patients who achieved MRD negative status after induction. Although disease-free survival did not differ significantly between the patients who underwent transplantation and those treated with chemotherapy alone, The wide 95% confidence interval shows high variability in outcome and suggests that the study is underpowered. A report from the COG was published in the JCO 2019 that hematopoietic stem cell transplantation did not improve the poor outcome of children with hypodiploid ALL. This study included 131 hypodiploid ALL patients and reported a 5-year event-free survival and overall survival of 52% and 59%. Hematopoietic stem cell transplantation did not show significant impact on survival. The 5-year event-free survival was 56% with transplant and 48% with chemotherapy only. And the 5-year overall survival was 65% with hematopoietic stem cell transplantation and 53% without. Hematopoietic stem cell transplantation had no significant effect on outcomes regardless of MRD level at end of induction. Patients with negative MRD had a 5-year event-free survival of 66% with transplant and 60% without. Patients with positive MRD at end of induction had dismal outcomes regardless of hematopoietic stem cell transplantation. The event-free survival at 5 years was 29% with transplant and 16% without. So the question is, how can the outcome of hypodiploid ALL patients with a poor response to induction therapy be improved? These patients are prime candidates for novel treatment regimens due to their consistently poor outcome. Noting that both near haploid and low hypodiploid ALL have activated RAS and PI3K signaling, Onfeld et al. Investigated the sensitivity of cell lines and xenografts to MEK inhibitors, as well as to PI3K inhibitors and dual PI3K and mTOR inhibitors. The MEK inhibition did not have an effect, while the PI3K inhibitors and the dual PI3K and mTOR inhibitors reduced proliferation in all investigated tumors. Inhibition of PI3K pathway may be a novel treatment options for hypodiploid ALL. Also, treatment options with CAR T cells and monoclonal antibodies may be useful. Small molecule inhibitors and immunotherapies could potentially be a bridge to hematopoietic stem cell transplantation to deepen remissions and to improve post-transplant cure rates. CAR T cell therapy has potential as a definitive therapy. In conclusion, the high frequency of germline TP53 mutations in children with low hypodiploid ALL prompts further counseling and genetic testing of family members. Increased risk of future malignancies in survivors of low hypodiploid ALL must also be considered. Transplantation is not indicated for patients with hypodiploid ALL with negative MRD status after remission induction. The role of immunotherapy in the treatment of ALL is expanding rapidly and may prove to be beneficial, especially for hypodiploid ALL with poor response to induction therapy on current treatment protocols. And finally, I would like to acknowledge all of our ALL study team members from different departments. And thank you for your attention.